All right, nursing students, you ready for this? We're diving deep into something you're going to see a lot in the clinical world.
Oh yeah, ABGs.
Arterial blood gases. And I know at first it's like another lab value to memorize,
Right.
but trust me.
But this one's different.
Yeah, it's not just a number, it's like a window.
It tells a whole story.
It really does. Like a snapshot of what's going on with your patient's lungs, their oxygen levels, their acid-base balance, the whole 9 yards.
Exactly. So we're going to break it all down. All the essentials you need to know as a nursing student.
Plus, I'll throw in some of the clinical insights
Oh yeah, those little pearls of wisdom.
that you might not find in your textbooks.
The stuff they don't teach you in school, right?
Yeah.
So let's unpack this, shall we? What are we really talking about when we say ABGs?
So imagine this. You have a patient, right? And they're not looking so good. Maybe they're having trouble breathing. Maybe their color is off.
Those classic signs of respiratory distress. Right. But sometimes symptoms alone don't tell the whole story. You need to know what's happening on the inside.
And that's where ABGs come in.
Exactly. ABGs give you that inside scoop. They can reveal problems that you might not see just by looking at the patient. Problems that could be life-threatening.
Okay, so we're not just talking about, like, is the patient breathing or not breathing?
No, it's much more nuanced than that. Let me give you an example. Say you've got a patient with COPD, chronic obstructive pulmonary disease.
Right. We're going to see a lot of those.
Absolutely. Now, a lot of COPD patients, they walk around with a slightly elevated CO2 level. It's their baseline.
They're normal, so to speak.
Right. But what if they start to get worse? What if their lungs are really struggling? An ABG can tell you if their CO2 is just a little high, like usual, or if it's dangerously high, a sign of a potential crisis.
That's actually really helpful because you might not see that just by looking at them.
Exactly. And that's why ABGs are so powerful. They can be the difference between catching a problem early
And missing it.
and potentially,
Having a bad outcome. So how do we even get an ABG? What is it exactly?
So it's a blood test, but not your typical vein blood draw.
Oh, no, this one's a little more exciting.
Yeah, we're going for arterial blood, that bright red, oxygen-rich blood that's pumping through the arteries.
Straight from the source.
Exactly.
Right.
And that gives us a real-time look at what's happening with the lungs, the oxygen, the pH.
Okay, so it's like a snapshot of the respiratory system in action.
Precisely. And it all boils down to 5 key components. Think of them as the Fab 5 of ABGs.
Oh, I like that. Hit me with number 1.
All right, first up is pH.
pH, okay? Like litmus paper back in high school chemistry.
Yeah, you got it. It tells us how acidic or alkaline the blood is.
Acidic, alkaline, important stuff.
Very important, because even tiny shifts in pH can have big effects on how the body functions.
Okay, so what's the normal range for pH? Just so we have a reference point.
All right, so normal pH is between 7.35 and 7.45. Anything below 7.35, we're talking acidosis.
Too acidic.
And above 7.45, it's alkalosis.
So it's like a balancing act, right?
Yeah, absolutely. The body is always trying to keep that pH within that tight range.
And the ABG is our way of seeing if it's succeeding.
Exactly. And that's where the other members of the Fab 5 come in. They help us figure out what's causing that imbalance, whether it's a problem with the lungs, the kidneys, or something else entirely.
Okay, that makes sense. So let's meet the rest of the crew. What's next after pH?
All right, next up we've got PO2. That's the partial pressure of oxygen in the arterial blood.
Oxygen, the stuff we need to survive.
Exactly. So PO2 basically tells us how much oxygen is available to be delivered to the body's tissues. Those muscles, organs, everything that needs oxygen to function.
So it's like measuring the oxygen supply chain, making sure all the cells are getting their share.
Exactly. Now, ideally, we want to see a PO2 between 80 and 100 millimeters of mercury, or mmHg for short.
Good to go.
Anything lower than 80, and we start to worry about hypoxemia, meaning the blood isn't carrying enough oxygen.
And that's bad news, right? Like the cells are starting to suffocate.
It can be very serious. But here's the thing. It's not just about the number itself.
Wait, what do you mean?
I mean, a PO2 of 70 might mean something completely different in a young, healthy person versus someone with a chronic lung condition.
So context matters.
A lot. You got to look at the whole picture, the patient's history, their symptoms, everything. Interpreting ABGs is like solving a puzzle.
Interesting. Okay, so it's not just plug and chug. We got to use our brains with this one.
Exactly. And that's what makes it so interesting, right?
Absolutely. Okay, so we've got pH, we've got PO2. What's next on our Fab 5 list?
All right, next we have PaCO2. That stands for the partial pressure of carbon dioxide.
Carbon dioxide. Okay, so if PO2 is about oxygen, PaCO2 is about the waste product, what we breathe out.
You got it. PaCO2 tells us how well the lungs are getting rid of that CO2. And remember, CO2 is acidic.
Right. Too much CO2 makes the blood more acidic.
Exactly. And that can throw off that delicate pH balance we were talking about. If PaCO2 is too high, it can lead to respiratory acidosis.
And if it's too low?
Then we might be looking at respiratory alkalosis. The blood becomes too alkaline.
Okay, so that pH is really trying to walk a tightrope between these two.
It really is. The normal range for PaCO2 is between 35 and 45 millimole Hg.
All right, so we've got 3 down, 2 to go. What's next?
Next up is HCO3 bicarbonate.
HCO3 bicarbonate. Okay, that one rings a bell. It has something to do with pH balance, right?
You got it. Bicarbonate is like the backup singer for pH. It acts as a buffer, neutralizing acids in the blood and keeping that pH in check.
Like a peacekeeping force?
Exactly. And the kidneys are the ones in charge of regulating bicarbonate.
So if HCO3 is out of whack, it might mean the kidneys are struggling.
Precisely. The normal range for HCO3 is 22 to 26 milliequivalents per liter, or MEQL.
MEQL, okay. And just like with the others, if it's too high or too low, it can throw off the pH balance.
Right. Too low, we could have metabolic acidosis.
And too high?
Metabolic alkalosis.
So we've got the lungs playing a role, we've got the kidneys playing a role. This ABG really is like a full body checkup.
It really is. And last but not least, we have SO2.
SO2.
Mm.
That's the one we see on those pulse oximeters they clip on your finger.
Exactly. Oxygen saturation. It tells us what percentage of hemoglobin, the protein in red blood cells that carries oxygen, is actually saturated with oxygen.
Okay, so like how full those little oxygen tanks are.
Perfect analogy. We want to see that SO2 above 95% ideally. Anything lower, and again, we start to think about hypoxemia.
So we've got our Fab5, pH, PO2, PO2, HCO3, and SO2.
And each one tells us a piece of the story.
Oh, like piecing together a puzzle.
Exactly. And as nursing students, you're going to learn how to put all those pieces together to look at the ABG in the context of the patient's symptoms, their history, everything.
And use that information to provide the best possible care.
That's the goal.
Okay, so we've met the ABG, Fab5, right?
Right.
We know their names, we know their ranges.
Yeah, the basics.
But how do we actually use this information at the bedside, like real world nursing scenarios?
All right, let's put on our clinical caps and walk through a few cases. Imagine you're in the ER, your first clinical rotation, and a young patient comes in super anxious, breathing like crazy.
Oh, I can picture it now.
And they're complaining of dizziness.
Dizziness, rapid breathing, sounds like a panic attack.
Yeah, classic presentation. But how can an ABG help us here?
Well, we know they're breathing fast, so they're probably blowing off a lot of CO2.
Good thinking.
Which would make their PaCO2 low.
Low PaCO2.
And that would make the blood more alkaline, so the pH would be high.
Bingo. You just described respiratory alkalosis.
Respiratory alkalosis, okay.
And the ABG would confirm that, giving us that objective data to support our suspicion.
So it's not just about calming the patient down. We can actually track their CO2 levels and see if they're improving.
Exactly. The ABG gives us that real-time feedback. Okay, let's switch gears. Now you're on a med-surg floor and you've got a patient with COPD and they're starting to have more trouble breathing.
Okay, COPD. We know their lungs aren't as efficient at getting rid of CO2. So their ABG is going to be important here. What would we expect to see?
Well, if they're retaining CO2,
right,
their PaCO2 is going to be elevated.
High PaCO2.
And that's going to make the blood more acidic.
So low pH.
Yeah, respiratory acidosis.
Respiratory acidosis. Okay, got it.
And depending on how severe it is, their PaO2 might also be low, meaning they're not getting enough oxygen.
So the ABG helps us figure out how bad the exacerbation is and if they need oxygen, right?
Exactly. It's like a window into their lungs.
I like that analogy.
Yeah.
Okay, one more scenario. Let's say we're in the ICU and we have a patient with diabetic ketoacidosis, DKA.
Ah, DKA. Now we're talking metabolic.
Right. This one's not primarily a lung problem.
Right.
But it still affects the ABG.
Big time. Remember, in DKA, the body starts breaking down fats for energy.
Because it can't use glucose properly.
Right, and that produces ketones, which are acidic.
So the blood becomes more acidic.
Exactly. What do you think we'll see on the ABG?
Well, the pH is going to be low, metabolic acidosis.
Low pH.
And I'm guessing the HCO3, bicarbonate, will also be low because the body's trying to buffer all those extra acids.
You got it. HCO3 goes down as it tries to neutralize those ketones.
Okay, starting to make sense.
But here's where it gets even more interesting. The body's smart, right? So it tries to compensate. If the pH is low because of a metabolic problem, the lungs might try to help out.
By breathing faster.
Exactly. Blowing off more CO2 to raise the pH.
So we might actually see a low PACO2 as well, even though the primary problem is metabolic.
You nailed it. It's like the body's playing this intricate balancing game and the ABG is showing us all the moves.
It's pretty amazing when you think about it.
It is, and that's why ABGs are so valuable. They give us so much information about what's happening inside the body.
Way more than just a simple lab value.
Oh yeah, they're a critical thinking tool for nurses. All right, so we've talked about interpreting ABGs, we've looked at some clinical scenarios,
We're getting the hang of this.
but there's one more piece of the puzzle.
Uh-oh, what's that?
Actually getting the ABG sample.
Oh, the dreaded arterial stick.
I know, it can seem intimidating.
But we got to learn it.
Absolutely. And once you do, it's really not that bad.
Okay, talk me through it. All right, let's talk about the actual procedure. Where do we even draw an ABG from?
So the most common site is the radial artery.
The radial artery.
It's in the wrist, pretty easy to find, and it's got good collateral circulation.
Collateral circulation, that's important, right?
Super important. It means there's a backup blood supply to the hand, just in case something happens to the radial artery during the procedure.
Like we accidentally damage it or something.
Exactly. We never want to compromise blood flow to the hand.
Which is why we do the Allen's test.
The Allen's test, yes. It's like our insurance policy.
Our way of making sure it's safe to proceed.
Absolutely. It's a quick test to check that the ulnar artery, that other artery in the wrist, is working properly.
Okay, so how do we do the Allen's test? Walk me through it.
All right, so first, have the patient make a tight fist. Then you're going to apply pressure to both the radial and ulnar arteries right here in the wrist.
So we're basically cutting off the blood supply temporarily.
Right, just for a few seconds, the hand will start to turn pale.
Okay, I'm picturing it.
Then you release the pressure on the ulnar artery only while keeping the radial artery pressed down, and you watch the hand.
But we're watching for color to come back.
Exactly. If the hand flushes pink again within, say, 5 to 15 seconds, that means the ulnar artery is good to go. It can supply blood to the hand if we need to use the radial artery for the ABG.
Okay, that makes sense. But what if the hand stays pale?
Then we know there's a problem with the ulnar artery, and we wouldn't want to use the radial artery. We'd have to find a different site.
Like the brachial artery, maybe.
Exactly. Safety first. All right, so let's say we've done the Allen's test and everything looks good. We're ready to actually draw the ABG. What happens next?
Okay, I'm ready for this. Break it down for me.
So you've got your supplies ready, you've prepped the site with antiseptic, you've located the radial artery. Now you're going to insert a small needle, usually at a 45-degree angle, into the artery.
And we're looking for that flash of blood, right?
Yes. Arterial blood is bright red, and you'll see it pulsate into the syringe. That's how you know you're in the right spot.
That must be a good feeling knowing you got it.
It is. All right, so you've collected enough blood, usually about 1 to 3 milliliters.
Not a huge amount.
Nope. Then you remove the needle and apply firm pressure to the site.
Firm pressure. Why is that so important?
Because arterial blood is under higher pressure than venous blood. So we want to make sure we stop the bleeding quickly.
Okay, so hold that pressure for at least 5 minutes.
For at least 5 minutes, yeah. And then, of course, we label the sample carefully and get it to the lab ASAP.
Time is of the essence with ABGs, right?
Absolutely. Those gas levels can change quickly, so we want to make sure we get the most accurate results.
This all makes so much sense now. From the interpretation to the clinical scenarios to the actual procedure.
See, it's not so scary once you break it down.
Definitely not. I feel much more prepared now.
And that's the goal. As nursing students, you're going to see ABGs all the time. So the more you practice, the more comfortable you'll become.
It's like anything else in nursing, right? Practice makes perfect.
Exactly. Don't be afraid to ask questions, double check your work, and learn from every experience. It's all part of the journey.
This has been an incredible deep dive. Thank you so much for sharing your expertise and for making ABGs a little less intimidating.
My pleasure. And to all the nursing students out there, keep up the great work. You've got this.
That's it for our ABG deep dive. We hope you learned a lot and that you feel a little more confident about tackling this essential nursing skill.
Keep those brains engaged and never stop learning.
Until next time, stay curious and stay compassionate.